So the cost of medical care at the end of life is a very large fraction of what we're spending as taxpayers and as patients on medical care in the United States. It's about 25 to 30% of what we spend in a given year in the Medicare program goes towards the 6 to 7% of patients within the Medicare program who pass away. So it's a very large pool of resources that we're providing to people in the last year of life. And what we want to do, because it's so large and because we know that that very large pool of resources is going to care that doesn't necessarily align with patient preferences for what they'd like to receive at the end of life, there's an enormous opportunity within there to redesign how we interact and pay for provider-patient interactions in the office or over email or over the phone so that we can better align patient preferences and actual treatment patterns with what's actually provided in practice. From the perspective of physicians, there's really two things you can think that would help us achieve better value in the care that we're giving, or that physicians are giving. One is just better information on what populations a particular technology works for and what it doesn't. We really have very little information, and most of the clinical guidelines out there are either inconsistent or scarce or even non-existent. So there's an enormous gray area of clinical practice today with just a lack of information on what patients actually benefit from a given procedure or technology. And then secondly, creating a reimbursement system through which that rewards the elicitation of preferences and not necessarily the application of technology to the patients. And so those two things can really help better align not only patient preferences, but the application of technology to clinical practice in ways that improve the quality of care in the U.S.